you for supporting us as always. Great to see some new faces and some regular people. So we really like to have these monthly events to share some new technology and some good approaches to optimizing brain health. And obviously, very happy to sponsor every month for here in the clinics. And I'm sure you all know what we do. We do SPECT imaging to try and see the root cause of what's going on in the brain. But I want to introduce our guest speaker today, Dr. Russell Teams. He has been board certified chiropractic neurologist through the American Chiropractic Neurology Board since 2013. His specialist training in chiropractic neurology focused exclusively on the rehabilitation of the nervous system, encompassing both the central and periphery systems. With extensive experience in functional neurology, Dr. Teams has treated thousands of patients with complex conditions such as postural orthostatic tachycardia syndrome, POTS, as we probably know it familiar, dysautonomia, traumatic brain injuries and concussions, complex migraines, and sympathetic dominance, which can lead to nervous system dysfunction. Beyond his clinical expertise, Dr. Teams has also mentored and coached hundreds of doctors worldwide. So we have an international speaker, our first international speaker today. And he's going to be sharing his knowledge and approach to functional neurology, which is becoming much more mainstream in patient care. So without further ado, I give Dr. Russell Teams.
Thank you. Thank you. This is Dr. Rachel. She's one of the doctors at our clinic. And so for what it's worth, I plugged that into AI to try to clean it up a bit, and so that's why it might have sounded too scholastic. Just throw that out there. So of course. So, we've only got about 45 minutes to cover all this. We could talk about this for hours, but this is something that Dr. Rachel and I feel very confident in, if my computer works. And we love working with these cases because we find that, and I apologize if there's cardiology in here that does work with these, but a lot of the cardiology offices around the valley don't even seem to understand what they need to do with POTS. We spent most of last year trying to network with all these offices, and they said, we don't even see it, we don't know what to do with it. So, what do we do with it? And so we try to educate and meet, and that's part of what we're going to finish with today is how we can start to network and find these patients the best route of care, or at least be a part of the team that helps them get there. So that's really the overall intention of today, is to try to really meet like-minded practitioners or anybody, CEOs, so that we can find the patients that we can help together get the best result. So without further ado, by the way, AI, you're going to notice that a little bit more. I just think it's kind of cool. And so the premise here is most people think POTS is cardiology. Well, it's not just cardiology. It's influenced by the neurological system, and so we have to look at both of these things. The neurological and the autonomic system, you just cannot separate the two. And so I wanted to start with this complex AI picture to help us really understand all the little pieces that we're looking at. We can make it extremely complex, but we're going to try to keep it very simple, because the simple things are what our patients are usually going to be able to do, as opposed to make it so complex they have paralysis by analysis type of things, okay? And so I'm going to be walking around, if you guys don't mind. I'll talk from the back of the room, I'll talk from the front of the room. I might read off the slides, I might not. You're fine. And so really we're trying to look at this from a paradigm shift, right? So functional neurology might not have had the best reputation because a lot of us chiropractors are delivering it. That's here or there. But at the same time, we have the tools, meaning that we can't use drugs, we can't use surgery, so we have to find a different way to work with these patients. And in order to do that, we have to shift the paradigm. We have to find another way into the system. And so that's what we're going to try to talk about today. If you're not familiar with POTS and dysautonomia, and by the way, I've had plenty of coffee today, so if I'm going too fast, you guys start to raise your hand, okay? Dr. Rachel knows I can talk, and I can talk fast, so I'm going to try to cover everything. POTS and dysautonomia are diagnoses. They basically describe what's going on, right? So POTS, postural orthostatic tachycardia syndrome, when you stand up, your heartbeat goes up in the absence of orthostatic hypotension, which is weird because that's one of the subtypes of POTS. Then we've got that dysautonomia word. So dysautonomia by nature is an umbrella term, which is cool until you start posting stuff on the internet and everybody says that it's not dysautonomia because that could be X, Y, and Z condition. So we're going to focus mostly on the concept of dysautonomia, so dysfunction in the autonomic system, something that we can really do something about, as opposed to things that we might not be able to do something about. And I'm going to throw something like multiple systems atrophy out there, like that's under the umbrella, but that's not something we're going to necessarily talk about today, okay? Who here is fairly familiar with POTS and dysautonomia? Raise your hand. Okay, cool. So I'm going to go a little more detailed on what these things are. So POTS is more of that heart rate rising, and typically the patients are going to present with these symptoms: lightheadedness, fatigue, heaviness in their legs, brain fog, focus attention issues, anxiety issues, TMJ, migraine. The dizziness one is very common that we're going to see. In the absence of vestibular dysfunction, right? We see it all the time. In the absence of vestibular dysfunction, you can have people describing they're on a boat. They can say they have vertigo, but 9 times out of 10 they're not spinning, right? And that's what vertigo really is, right? It's more of a positional spin. And so we have other things: heart palpitations, sweating, heart rate increase or decrease, fainting, chest pain. We're going to go over a couple of cases that had some of this chest pain as well. And then we're going to talk about the sympathetic dominance side of things, right? So to keep that simple, burnout, right? We can talk a little bit about burnout and how that affects or impacts the neurological system and the autonomic system. So we've got a couple of cool cases. We're going to try to get through them. Did I start my timer? I did. So Dr. Rachel's got one, I've got two. One is going to be POTS, another is going to be the sympathetic dominance, and hers is kind of a combination of the two, which is really cool. So ultimately, we're going to talk about all the stuff we have to address, or at least have to look at and consider, in order to ultimately help this person get all the way to the end, as opposed to just doing your piece. We all have our piece, right? I always talk to patients, your case is like a puzzle. There's either this much or this much of what we do. There's either this much or this much of what they do. When we put them all together, we get the whole picture, right? Does that make sense to you guys? The thing that I always come back to is we don't always have to have one thing that's going on to cause these problems. When we're looking at the sympathetic dominance, you're seeing TMJ issues, migraine, IBS, insomnia, hypertension, heart palpitations, digestive issues, chronic fatigue, anxiety. You can have dizziness with this as well. How many people go into a panic attack, they get dizzy, they get tingling, they get numbness, and their valves stop working? Well, it's kind of the same thing in a POTS situation, right? Because they're just not getting enough blood flow to their head. So they're like overlapping issues, and you can have one of each, which we're going to show as we go over some of these cases. Let's see. This guy we'll touch on at the end. I think we're going to run a little long, and so we'll touch on this stuff all at the end instead of going over it now, okay? Does there have to be one thing causing all of their conditions? No. How many times do we see, how often have you guys seen textbook? Very rare, right? That drove me nuts, because I think I've seen maybe T4 syndrome once in my whole life, and it was textbook, right? Everybody else has cervical issues, you've got sympathetic issues, you've got blood flow issues, they sleep wrong, whatever it is, basic chiropractic stuff. There's so many things that are overlapping. We can do a lot of things to help these people. So POTS, we kind of touched on this. It's dysregulation of blood flow to the brain, and it tends to cool the feet when we stand up. When you talk about cardiac output and achieving the right amount of blood to the head, you have to have pressure, you have to have rate in order to get that to the brain, right? On top of that, you've got this neurological system that works with the autonomic system to tell you where to send that blood flow, right? We're going to cover here very shortly that chronic stress decreases blood flow to the prefrontal system. And what does the prefrontal system do? It basically gates everything, right? It inhibits all the bad stuff that we want. Right here. So chronic stress, particularly those involved in higher thinking, prefrontal cortex, and it allows the amygdala to start to escape, right? To become dominant or sympathetically dominant, okay? Again, you guys throw your hands up if I start going like this with my speech, because I think I'm a little more pressed for time than I practiced, okay? So we're going to briefly go over the 3 types of POTS. So we're going to have hyperadrenergic, which is more of your sympathetic overdrive version. Okay, you guys feel free to take pictures, and I can send something like this to you guys afterwards. I can just send it to Melvin, he can send it out to you guys. But your symptoms, palpitations, anxiety, tremors, increase in blood pressure, sweating, headaches, right? So we know that that sympathetic system is dominant here. In CAS, whether it's the chicken or the egg, a lot of times you have to address that, and honestly across the board. Things like mold and mycotoxins, you have to consider that inflammatory cascade, which fires up the immune system, which can put that system into more of that sympathetic overdrive, trying to save you. And then we talk a little bit about treatment on the bottom, so different medications are used for different aspects. I don't do medications, Dr. Rachel and I do not use medications, but we have to work around them all the time. Hypovolemic. The hypovolemic is going to be more of your syncopal type of patient, right? So this is the person who actually stands up and passes out. They don't just get lightheaded and feel like they're going to pass out, because we found that can also be the hyperadrenergic cases, okay? Again, different medications for different reasons. Neuropathic POTS. So this is going to be the one where people typically develop some type of neuropathy. This might start getting more into the autoimmune types of cases. What do we know about, who here deals with autoimmunity? Raise your hand. Okay, I'd say half the room, if not more. What do we know about autoimmunity and the stress response? Is it good or bad? Bad, right? Long-term stress response sounds like it's becoming more and more of the cause to open the door for the immune system to dysregulate and attack itself. Would we agree on that?
Yes.
Yeah.
Are you guys that don't deal with autoimmunity, or do you guys understand that part? Cool, all right. So ultimately, when we're looking at all these POTS and sympathetic dominance type stuff, that sympathetic nervous system is almost always involved to some degree, right? It's generally the one that spins after they start to get their symptoms, right? Whether their symptoms came from trauma or a head injury or an infection, that sympathetic system typically becomes dominant, because these people are going around and around, doctor to doctor to doctor, telling them, being told it's all in your head.
Yeah.
Who hears that?
Yeah.
It's all in your head, there's nothing we can do, just go home, sleep it off, relax, manage your stress, you'll be fine. And these people are not fine. So there are some basic criteria. 30 beat increase from laying down to standing on a pulse oximeter, or like your heart rate. If it goes more than 30 for an adult, that's considered positive. If it goes more than 40 for an adolescent, that's going to be positive. Speaking with one of the cardiologists in town that treats these cases pretty regularly, we don't do a typical tilt test, right, where you're strapped into the table and your legs are dangling, because all of us are going up against gravity, right? We have to activate all of our lower extremity and all our muscles, and so we like to do more of a functional test or a modified supine to standing test in order to get more of a natural what's actually happening kind of thing. By the way, when we talk about symptom duration, just probably in the last year or two, we've been starting to see people closer to 6 to 12 months, when usually it's 2 to 4 years before they even get a diagnosis, let alone find the right clinic to help them, okay? So these people are pretty well struggling, or pardon my French, but screwed for quite a while until they get in front of the right practitioner. So the typical process goes like this. You're gonna typically see your PCP. They're gonna refer you to neurology. They might refer you to cardiology. They might refer you then to rheumatology, right? We talked about all those different subtypes having autoimmune issues. And you guys see it here, right? These guys see a lot of brain injuries which end up having dysautonomia, which, by the way, you guys just sent me somebody that I saw yesterday. Totally normal neurology, completely screwed up autonomics. And so what are we gonna do for that? We can talk about that at the end. Again, the typical diagnostic process is your tilt table testing. So this is the room they walk into when they feel like that. How many times is that room gonna make somebody who's already on the verge of like falling apart feel good? All right, and it's like when you're doing this test, and usually it's like Mayo and I think Honor Health, is that? So there's 2 major clinics in the Valley that are doing this testing, but they don't really have any treatment for it. That's the downside. So they walk in, they do this, and then they hold them here in an upright position for 10 minutes. When you have no leg activity, of course your blood's gonna pool. All of us are gonna show up with some type of modified dysautonomia, right? Some of the studies have shown that it's like a pretty high number of people showing false positives with this type of test. So 1, it's very extensive, but 2, it makes people feel terrible. They might crash for 24 hours, they might crash for 24 days afterwards. When you go on Reddit and you see what people say, they're like, I'm never gonna do that again. Luckily, you don't have to right now, but we need to know when the system changes, which is what we're gonna show you later. So other considerations, genetic factors like Ehlers-Danlos, hypermobility type of stuff. Sorry, I would walk through there, but there's no room. And so we've got genetic factors, we've got family history, we've got autoimmune issues, and then we've got infections. Anybody know of any infections recently that have been causing things like POTS? We got flu, bird flu, we got COVID, right? I can say that in a closed space. But now with that, we have to look at, is it just COVID by itself, or were there other risk factors present beforehand? Same thing with a concussion, right, Doc? We always have to look at what was going on before we started cooking the meal. What I mean by that is, was there heavy stress? Was there trauma? Was there already an unstable system, and then boom, you hit it in the head? Or boom, you get ill. Well, how many people have had COVID and recovered from it fine? How many people didn't? The ones that didn't, we've got to look at all of these aspects so we can optimize those or reduce the risk factor of it happening again. Does that make sense? Mm-hmm. Cool. All right, we talked a little bit about the car accidents, which is what they referred us, falls, sports, people just messing around. We had a kid who was wrestling with his 22-year-old teammate or roommates, got a concussion, right? This individual is on the spectrum. Is what he dealt with before going to reduce or going to amplify after head injury? That's right. And so for what it's worth, this is kind of a clinical note, it's not really in here, but anybody with ADHD, one of those hyperactive go type A personalities, they hit their head, I would probably say 99% that's going to turn into pretty significant anxiety. Have you guys seen that? Mm-hmm. And so they wonder, why is this happening? You have to be able to explain it to them so that they can make a little sense and create some clarity so that they can feel better and find some hope in the whole thing, right? So it all makes sense. It's not just in their head, right? A list of medications. We kind of looked back earlier. I was going through, Stand Up for POTS. They have different medications for different treatment protocols or for different subtypes of POTS. I just pulled that from that website. Because we don't deal with the meds, but when we see the meds, we need to understand what their doctors try to accomplish. So we don't do that, just so you guys know. So what is the typical approach to dealing with this stuff? We talked a little bit about stress modification, right? Increasing our fluid intake, increasing the salt to try to keep that fluid into the vessels a little bit more. There's like 1,000 electrolytes out there and they're all trying to kill us, I think, but at the same time, right, it's like some people need this stuff to be able to just get out of bed. And so it's necessary. The goal is to not need it, because at some point they didn't need it. Why do they need it now? Right? What changed to make their system not be able to heal and regulate itself? So going back to all those risk factors, we just have to look at all of those. Exercise typically, I can't remember the name of the PDF, I'm drawing a blank. I think it's out of Utah. That's a PT Utah thing where they have a whole progression of exercise and it takes like 6 to 12 months. Mm-hmm. Dallas, there's a Dallas protocol, and I think there's another PT thing out of Utah. And so they're saying, yeah, it's going to take a minimum of 12 months for you to start feeling better, which is pretty scary. And in some cases that's true, depends on what's going on in the case. Let's see, aiming for 30 minutes a day, that's what a lot of the research says. We say it's completely dependent on what the patient can handle, right? Tolerance is a big piece. Compression garments, in all honesty, what is pictured right here, I put it up here because I didn't realize for the longest time that many people have to wear abdominal compression garments because that's a secondary place for all the pooling to happen. So you can wear the stuff on the legs, but you're only a little bit better, and then it all pools here instead, right? So when we look at where things pool, what are things that we're gonna have to do to effectively get the blood back up to the head, okay? The obvious one, manage sleep and stress, right? We all know we recover when we sleep, so I won't even worry about that. I think a lot of that stuff that's on there is pretty basic things that we would probably do. If you're here eager to learn, that type of stuff is probably already conversations you're having out of that. right? Functional neurology, we're going to dive a little more into what we do and how we do it and how it can be effective. What is this one? Oh, and then what role does psychology play? We're in a great clinic today for that, aren't we? Does anybody have any idea? First hand that goes up, what kind of role does psychology play in a case like this?
Well, I would assume an emotional response is also connected to how they feel.
Sure.
So you have emotional stress and you have probably difficulty with coping,
Sure.
less ability to be present.
Yep. And so the inability to be present, because one, you're focused on something inappropriately when you should be here, that's more of a basal ganglionic frontal lobe function.
Right.
And what do we say about maybe a chronic stress? Where does that take blood flow away from, right? And what other part of the brain, it's about yay big, that controls most of our life when we're scared. It lights up that amygdala. So the question becomes, when do we treat the psychology? How many of you have seen people go to the same practitioner, whether it's a counselor, a therapist, or other psychotherapist, psychiatrist, and they're with that person for 10, 15, 20 years, and their function is not really improving that much. That's the one I'm concerned about. I'm not worried about the people that get better, because they were in a place to get better. What we see is people anywhere between like 10% function and about 50 to 60% function that try to go and do psychology work, and it flares them up every time they do it, right? Because that nervous system strength is down here. They need to be here to heal. They might need to remove that psychology stressor to get them up there, but those are usually the ones that don't do so well with therapy. Does that make sense? Yes, sir.
Have you experimented with ketamine, like therapy and stuff like that?
So yes and no. We have
emotional connection.
So yes and no. It depends on the case. We don't do it. We will refer, but generally the people are already on it. So we'll see like a bunch of treatment-resistant depression stuff, and those people have to go every week, kind of like ongoing, which is not really it's not a no-no, but it's not a yes-yes either. But what's funny in that case, this was a post-stroke case that came to us with 40 years of treatment-resistant depression, and it's started very simply. Went maybe a couple months that we were rehabbing the stroke, got better, but then she starts going into the depressive thing, which is now her main concern. So we draw a circle on the whiteboard, which for her is the mirror at home, and we write, I love you around it. She's had 40 plus years, probably closer to 60 years of not loving herself because of the trauma in her life. We had to rehab her to get her to the point where she was able to dive into that. She was on ketamine every single week for probably like 5 years, 4 years, something like it. It was like often.
Would that explain the difficulty some people have in making a change in terms of their behavior or their habits or their emotional sense of well-being? That change is the problem because they can't seem to negotiate how to make it.
So I would say this in two ways. I would say, yes, that's the problem because their system is weak and they can't activate their brain to motivate themselves. The other one is they don't have enough desire to make the change. And those that don't have the desire to make the change are probably the ones that fail in every one of our facilities. It's those that want to, and they will do the work that you want, they just don't know how yet, is the ones that can be coached, the ones that can be led and guided to the position of them being able to make that decision, right? Like people, like head injury cases, right? They have testosterone that's in the tanks. Well, most of these men, they don't have the motivation to actually go to the doctor to get it done, right? They're just surviving. So the last thing they're gonna wanna do is optimize. They have to have a heavy emotional reason to do so, which is gonna fire more of that amygdala, frontal system, that motivational piece to get you to that point. So I could argue every single case is like that. You just have to feel it out in the history. So this guy, this is what we generally use for, sorry, I'm gonna carry my phone around for timing. This is generally the table that we use to help establish where people really are. So in our intake, we ask somebody, and it's a totally subjective question, what is your current level of function? And most people are probably anywhere between, the average is probably between 25 and 60, right?
what we found is at 65% or above, on average, people can still work. So when we ask and somebody says I'm at 50%, they say I'm still working, we have a little bit of a disconnect between what their body is capable of doing and what their mind thinks they're capable of doing. It gets a little hairy maybe in like 60 to 65 because of this remote work that everybody does now. So they can lay in their bed and work, which a lot of ours do. When we start getting into the 35 to 65 and below 35, clearly it's going to change the amount of work that's required, right? So this might be something close to 3 months. Well, probably here would be less than 3 months if somebody's trying to optimize. They might not even be our patient. It might be go to therapy and you're ready. Maybe. This is going to be closer to 3 to 6 months. This is probably going to be more like 4 to 8, and this is probably going to be closer to like maybe 6 to 12 months. That would be more for like somebody local, the reasonable, come in every couple times a week, like a personal trainer would. And then there's other people who we fly in from out of town that we'll do like 3-week intensives on. So they'll be in our office all day long, Monday through Thursday, doing rehab, testing to make sure we're moving in the right direction.
What's your thoughts on the TMS?
I don't know enough about it, but it's, from what I understand, it's like a super massive targeted PEMF device. We use PEMF on most of our cases if they can handle it. And so it just depends. So it's a great question. I can't answer that for you. I have a practitioner that I work with in North Scottsdale that could answer that question.
We have someone in the room that can answer that.
Yeah, okay, there you go.
TMS specialist.
So we can have her answer that. Okay. I hope I did that justice.
Yeah.
Okay. So this piece, let me see. This word right here is probably the most important word in this entire presentation. Tolerance. How many people have you known that might have gone through something like, oh gosh, I don't want to butcher anything. You go to a facility that has about 50 different offices here in the Valley that has a high protocol, pump people through kind of reputation. Does anybody know any facilities like that?
Oh, yeah.
You get what we give. We don't customize for you. You get what we give, you get what insurance pays for, good luck. That's pretty much what happens with most of these cases. They're gonna, because it's part of that original PCP, neurology, cardiology, rheumatology, go to PT. Well, we'll do imaging, there's nothing on imaging. Okay, well, we got nothing else for you. That's basically where these people are stuck. And so if we just modify some of that exercise that they did and kept it within their window of tolerance so they don't crash afterwards, they're gonna feel a heck of a lot better and they're gonna be able to build on that. And then the psychology of it, they won't be afraid to do it again. You guys with me on that? Okay. This is exactly what we're talking about. Day to day, they have a good day, they go and do all the things, they crash. We go to PT, we crash. Now this company, Visible, I just heard about them, I'm trying to get in contact with them. They have a concept of pacing. It's a new term that I've heard, but it makes perfect sense. We're gonna try to get you to stay under your line of exhaustion. Makes sense. But does that make them stronger? So that leads to, in my opinion, a lot of avoidance behavior, which anybody in the psychology world knows that that's a problem in itself. Your world goes from here, day after day, it just gets smaller and smaller and smaller. Our role, Dr. Rachel and I, and actually Dr. Janine, our role is to increase that level of exertion intolerance. So that, in our world, is getting the nervous system stronger. Does that make sense? Yeah. Cool. All right, so this is kind of where we toot our own horn, but generally we're gonna work hard and we're gonna try to provide these types of outcomes. Changes in heart rate variability, stabilization of blood pressure, digestive systems start to improve. So basically they start to feel better overall, okay? And part of it's subjective because that's really, on one hand, all that matters is that patient has to feel better because that's what's gonna create some of their quality of life. On the flip side, we have to make objective changes so that we know they're actually getting better, right? And we can show them that they're getting better. So talking about objective stuff, so this is a patient of ours that was wearing her Whoop thing. She's super funny, lots of trauma in the life, doesn't want to admit it, but just has a smile on, is super bubbly, but can barely walk like, 20 minutes without getting like completely dizzy to the point where it's like 10, and I know I gotta be home and I'm gonna be down for like a while. The first month, I think it was, when we started seeing her, she started having like 20% improvements, 50% improvements, 4%, 16% improvements in all these different pieces. Yes?
What's your diagnosis?
She had POTS.
Okay, that's
And so with this, if we have a 20% decrease in her average level of stress, meaning non-activity, so just walking around, she reduced that level of stress by 20% in 30 days. And so this is like biometric feedback that she's giving us. We didn't even ask for this. She just goes, hey, by the way, I can now walk like a mile, and all I have to do is sit down for like a minute or two and I can walk back home and I'm all good. Which is huge for a patient like that. Because all she wants to do is get back to working out, which is part of every patient's, it could be this big or this big. So what we do in the office to evaluate this system is we do V&G, so an ocular motor assessment. Every part of the brain controls an eye movement or a different eye movement. So when we see abnormalities in those eye movements, we know what parts of the brain are impacted. Those parts of the brain integrate with other parts of the brain and they create really the symptoms that we have. And so we do V&G, we do a force plate assessment and then a timing, like a metronome type of assessment. We do our what's called a vital scan. You guys heard of a vital scan? So it's a 3-lead ECG, pulse oximeters, blood pressure cuffs all over the place, QSAR. So we do all of that testing, and it takes about 45 minutes to do all of that. So it's not like a whole day of testing. We can get people in just about every week to do that. And then we sit down with the patient and we go over all of it. Our role is to educate, because most of these people have just been told it's all in their head. So they need to understand what's going on, one, in order for them to make a decision on what they want to do about it. And so then we just have that conversation on what we can do for them. I don't know, I thought that was just a cool image, so I just threw it in there again. Bless you. So our approach is pretty well the same as you guys. We're going to evaluate the system, we're going to educate the patient, and then we're going to personalize a roadmap for them, right? Because no two patients are the same. They might do similar exercises, but they're going to be different amounts, different intensities. They might lay down, they might stand up, right? They might have to wear headphones, and they might do no electrical activity because their nervous system's too sensitive. There's too many things that could go wrong in a super sensitive system, so we have to be very careful as we approach these cases. How are we doing on time?
You're good. Okay, another 15 minutes.
Okay, cool. So we're gonna start going over, well first, does anybody need to stretch their legs and get blood to their head? Okay, so I'm gonna go over a couple cases. This one's mine, this is a really fun one. This is a patient who dealt with some trauma in the very beginning of her life, and it wasn't her fault. Patient's, oh gosh. The patient's grandmother had a husband who died on one day. This daughter was due on that day. She basically held it against the mom that you cannot have this baby on this day. I swear I am gonna blah, 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 blah.
Wow.
So the mother didn't give birth for 4 days. So she was basically ready to come out. 4 days later, she had her baby, which was on the day he was born. The grandfather. So you can't be born on this day, you can't be born on that day, she was born on that day. Okay? So the stress of the mom impacts the stress of the baby. Long story short, some of the worst ADHD that I've seen, but she's physically up to par. She was a captain of her soccer team, so at a young age of, I think it was 21 or 22. These are the symptoms she presents with. She used to play soccer once a week. She's a school teacher, so she's on her feet all day. Literally just fallen apart to the point where she had to do something. Highly dependent on mom, because mom is also a manager in a healthcare facility, so she's used to running the show. So now we have this dependency thing, this codependency mechanism going on, right? And so it's even harder because they are paying for her care. So like all these layers of psychology that are going on, we have to be able to navigate those. And so she's one of those cases that has seen a counselor for as long as she can remember. why aren't you any better? So that's not the main cause. And it might be, but in order to get you to heal, we have to improve the strength of that nervous system. If we use that chart of that percentage function, I think she came in around 40%, but she was still working every day. So we know she's about 60, 65. So there's a little bit of that discrepancy, right? Here's her autonomic testing. Excuse me. So this is over time. We've got heart rate in red, blood pressure in blue. We have a deep breathing, we have a Valsalva, and then we have a patient standing. Hard numbers are here. 78, when she stands up, she goes to 114. We know that's a POTS case. This is also the modified tilt test. So would this person be any better or worse if we did the hanging tilt test? Probably a lot worse. So we've got also that orthostatic issue going on. We've got focus and attention issues. We've got chronic stress. So we know the prefrontal system isn't working. And we've got a patient with POTS. In the beginning, I showed some of the medications. You guys can go back and take a peek at that. And so I think she's on 5 or 6 different medications to control these symptoms. And she was still feeling like 40, 50%, which is no good. So we just went to work, and within about 2 months, we were able to modify her findings to be sub-threshold for the typical POTS diagnosis. And when you look at what happens when she stands, right, see where that heart rate is?
Mm-hmm.
Oop, wrong button. We see a small piece of this, so she's not completely out of the weeds, but the remainder of that is she's moving towards homeostasis. And that was just 2 months. And she's been living with this for, I don't know, 6 years. And so it just shows the power of when you do the right stuff at the right time, what you can do. This might be a great referral for somebody like TNS. In my opinion, once they get to the point where they can start to kind of manage their own life, then it's like the icing on the cake is other things. How many times have you guys done something and it didn't work? I think our position is that it's that nervous system doesn't have the strength to do what it needs to do. It just flares too easily. It doesn't have the digestive capabilities to put in supplementation and to really absorb stuff. So when we strengthen the system, it's, in my opinion, it seems to work better. That's just me. I'm totally biased. It's my business. It's, all of that. Yes?
So can I ask what leads these people to you? Is it a physical malady, or like what do they generally come
I mean,
or do they already know?
it's really
What
that
are they
list.
coming like, oh, I just don't feel good, and here's all the things going on?
Most cases, probably as of about a year and a half ago, most of them know they have POTS
Okay.
because they go through PCP and then they get referred to neurology. And then it's like, it's almost the same
that
for
list,
everybody.
okay.
That list is pretty well gonna figure out what the problem is. The problem is in that list, most of the time, they're not able to like help those people to a degree they need to be helped. And so in this sense, in like a POTS sense, I kind of like to be thought of as like the quarterback, where we can figure out what we need when we need it. I had a case 2 weeks ago, she comes in with POTS and like she can't swallow. Maybe it was 4 weeks ago. And I work on her once or twice and she's like, this ain't working, da-da-da-da-da. So I do a little deeper history. Turns out there's way more trauma that she just doesn't talk about because she's already worked on that. Well, she was in a car accident, weakened the brain, opened Pandora's box, and now this thing she had from 50 years ago just popped back up. So I referred her out to hypnotherapy. Within 3 visits, she started swallowing it. And within, we're talking like 3 weeks. That's nothing that I did other than make the right referral. Realize, hey, these things actually seem okay, go see that person. I'm gonna pop over to, let's see, we should have enough time to. All right, so we're gonna look at some eyes here. So gaze stability is the ability to keep your eyes locked on a target. We all have to have that basic foundational level in order to basically process and read what we're looking at. What we do is an eye test. This would be a normal test. Okay, so we've got the right eye over here, the left eye over here. This eye is gonna show up in red. This guy's gonna show up in blue. The green line back behind here is the target that we want that person to be on. This is essentially normal, right? I'm not gonna treat this patient with neurology. The next case, this patient, we're probably gonna wanna do something for her.
Is
You
that
can
because
see.
the eye movement goes one way or the other?
And so this is normal because we're basically following the target. I was gonna put video up here, it was a nightmare, so I just didn't even do it, okay? And so what happens is dot will move to the right, this will move, and they keep their eyes on that dot, not coming off. Then it shifts to the left, then they keep their eyes on that dot, okay? So it would be like you guys, everybody look at this with your eyes only. We do that for 15 seconds, then everybody look over here. We're looking to see if the eyes are gonna move. Now this case, here's the target, here's their eyes. No bueno. No bueno. Now imagine if this person's walking through a store and they're trying to fixate on something so they can know what they need to buy. That's not gonna work out very well. This person had to leave the store every Sunday with their girlfriend because they would have a panic attack. So this individual was the second case study. 28-year-old ran a mortgage company, was in charge of like 30 people at the age of 28. So super go-getter, owned like multiple houses, just went, worked out 5-6 days a week. That's a recipe for burnout, right? So he comes in completely burnt out. He has POTS, he has significant anxiety. This kid was just a mess. But they're also the best patients because they'll do every single thing that you tell them and then some. Then we look at fast eye movements. Fast eye movements are generated by the front part of the brain. It's very hard to find perfect eye movements, isn't it? And so this is about as close as we're gonna get. Same patient as the first one. So pretty well normal. You can see the green here, you can see the red, you can see the blue. We're pretty well normal on this. This was the patient originally that we were just talking about. Can you see how wild that looks? Sorry, in my new way. This was the patient after 6 weeks. What's cool about this is we didn't even mess with the eyes until about 3 weeks in because they couldn't tolerate it. This was a year ago. So first one was I think 4/15, 2024. Second test was 5/28, so exactly like 6 weeks. And we haven't seen him since. They're only about halfway through their treatment program too. But those types of individuals who are go, 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 they do all their working out, they're gonna do their exercises, so we haven't heard from them. So that's a great case. Doc, you're up next.
All right.
That was perfect timing.
Almost.
All right. So I just want to quickly come up and talk about a patient that I treated last year. So she came in with a little bit different symptoms than a typical POTS patient. She actually was not POTS. She was actually having seizures. So she was a 54-year-old female. She had to retire she was a massage therapist, but she had to retire due to a completely different injury. But she came in because she was having persistent memory issues, just kind of came out of nowhere. She ended up having 2 seizures pretty much back to back while she was sleeping. She was diagnosed with ADHD, she had it her whole life. Brain fog, difficulty with reasoning, so she was doing something and she was like, why am I doing this? She was feeling certain emotions and she couldn't explain why she was feeling this way. So emotional dysregulation, issues walking, so pain with walking, and then temperature dysregulation. So I kind of had a little history of her in a couple slides ago, but basically she had 2 episodes of seizures, both in the middle of the night. It was like 3 a.m. Her husband was asleep in bed with her, and she just woke up screaming, shaking, crying, and just non-coherent to him. He was trying to wake her up, and just for a couple minutes, she just completely has no idea what's going on. And finally she came to, and she was terrified. She was like, she had no recollection of any of this happening. And of course, that's scary. You wake up, and your husband's telling you you were just screaming, crying, shaking, and you have no idea what happened. So she was obviously scared. So she went to her PCP. She got blood work done, got a whole workup. Everything came back normal. So they referred her to her neurologist. He did an EEG, sent her out for a brain MRI. Everything came back normal. So she was like, something's not normal. Why am I having these issues? And so that's kind of how she came and found us. She just needed some answers, and she wanted something to do. She was very active. She did bikini competition at 52. Like, she was a very, very hard worker, very dedicated to the things that she did. And so she came in willing to do the work. But some things that I found out during her history was that she was in a chronic state of stress her entire life. She had a lot of trauma growing up, and she was consciously working through it. She was aware of it, but she didn't understand what extent it was affecting her. You know, it was to a point where she wasn't functioning anymore. And about a month or so before her seizure, her mom passed away. And so, of course, very stressful and very emotional. And she was upset, but she kind of just brushed it under the rug. Like, there's no way me losing my mom would cause me to have memory loss, have seizures, and everything kind of go downhill. But a little digging, and we figured out, yeah, that's pretty much what happened. Her body basically just couldn't handle all the things that she was dealing with, and it just kind of snapped and broke. So with her, essentially, I treated her for a little over 6 months. Her actual program was about 4 months, so then we went on to a 2-month maintenance program. But in those 4 months, we did a comprehensive treatment plan that included the neuro rehab, so just kind of based off of the the eye testing that he just went over. We did vagal nerve stimulation, we did a lot of breathing exercises, and just lifestyle changes and modifications. You know, we were finding out what her triggers were. One of them was driving. She hated driving, stressed her out, and so we just had to modify things to allow her system to stabilize so she could go back to doing things that she really wanted to do. And essentially, you know, her progress was amazing. She was able to go back to doing the things that she loved. She was able to start working out again. The treatment that she was getting with her therapist, with her PT, with her pelvic floor, actually started working again, because none of it was working. She had surgeries, she had all these things that were just failing. And so everything kind of started working out for her again. She was able to do Pilates again, which was a huge success for her. That's really what she wanted to do. And then she was able to start traveling again with her husband, and overall she just regained confidence in herself. You know, she wasn't second guessing herself as to, you know, why she was feeling a certain way. She was okay with the fact that, you know, sometimes she was a little sad, and that was okay, and sometimes she was just feeling her emotions and understanding that it was okay to feel that way. But yeah, she was back working out again, traveling consistently, and she didn't have these what ifs, like, what if I have the seizure again? What if I can't dance when we're in Mexico? What if all of these things happen? And so she stopped having those what ifs and just gained her quality of life back. And so this was just a really fun and cool case that I was able to work through. And I have on the next slide just her results. So this was day 1. As we can see, not terrible, but there was definitely some things we needed to work on. And then about 4 months later, at the end of her program, pretty stable. Same one with those fast eye movements that we went over a little bit ago, the saccades. Saw a little breakdown here, and then we were able to get that normalized. She was a lot more stable, and so we did have a month or 2 after this of just maintenance, but at the end of this, she was just stable, and she was able to do all of her home exercises and keep her to a point where she stayed consistent and felt good.
She's not going to toot her own horn, but she was, this patient was trying to get her or us onto the Huberman podcast after the results, so it's kind of cool. Also, my joke is she actually was able to, after her results, she was able to refer in the root cause of the problem, her husband, and so she just got to start working with him. Okay, that's a joke. So the videos and things, they should pop up, but they're not. We're not going to deal with them here. It just bogs everything down, and it just kind of froze everything. So this is going to basically conclude our presentation today. I hope you really enjoyed it. I hope you learned some things, and I hope I started to shift your paradigm, or we shifted your paradigm a little bit. The next steps would be very simply, if you have any patients that you would like to refer with us, very simply just give the office a call. You've got the information, and we do a consult with everybody to figure out if we're a right fit or not. We do that with every patient before they come in, and then we just set up an evaluation. It's $250. Very easy, so people can learn and educate. We don't do really expensive stuff just because we want the opportunity to try to help a lot of people. We can usually get them in within a couple of weeks. you guys, we would invite you guys to come over and have a neuro experience. This is more like a one-on-one where you come into the office and you go through the evaluation, and we just talk to you as if you were a patient, and we say, hey, here's what's going on, but this is what every new patient would experience if you send them over, okay? So what we have, you can simply email or hit the contact us page from the QR code, and then just message the office, and somebody from our office will get in touch with you to set that up, okay? That's the QR code, we've got the tour of the office, the neuro experience, and that's about it. So that's Dr. Rachel and my presentation, and thank you so much for having us. All right, so we
Any
got
questions?
7 minutes of Q&A, first hand.
Cost,
Cost.
yeah, what is this cost for a
It
typical
depends,
patient?
it depends. So the range for anybody local is probably gonna be anywhere between $2,400 and $7,200, depending on what's going on. We have some that are in the tens of thousands, very rare. But then people coming in from out of town, we usually do like a 6 to 12 month treatment program, or maybe 6 month treatment program within like 3 to 4 weeks. So those are gonna be upwards of maybe 12 to 15, 16,000.
Okay, and do you have payment plans? I'm not talking about for myself.
Yes.
As somebody I'm working with that has POTS, she has pretty severe
Yep.
POTS.
Yeah, so we can do, we have prepaid discounts, we have payment plans, and we have care credit and things like that that we can take. But we will always try to work within somebody's budget first before we have to go to credit, for what it's worth. Because all of the things we do in the office work, we just need to know what somebody is gonna be able to do, right? It's all about that tolerance, budgetary, neurological, whatever it might be. Next question?
I was wondering if there was a age group that you would not be able to treat.
Yes, I have a friend of mine that treats the kids in the valley, and actually all over the country and really the world. He treats everybody basically under 9, 10 years old. We can pretty well see anybody else above that.
So like 80 and up.
80 and up is fair game, depending on what they have going on. I personally don't like, I don't think we love dealing with, at least I'm speaking for myself, Parkinson's neurodegenerative stuff. I refer that over to AZ Carver Neuro. Just not my thing.
I have one more question.
Yes.
Do you treat vagal syncope?
Yes. Yeah, we just evaluate, we treat, we'll be fine. But yeah, any of those symptoms that are gonna be syncopal based, we typically can do pretty well with. Anybody else? Yes.
Does your evaluation determine whether the patient has motivation to proceed?
No, yes and no. If we have a normal neurological test, why don't you have motivation? Is it just the autonomics are so bad that you can't get blood in your head? It'll tell us that. You look at the history, you look at, I'm here because my wife wanted me to be here. Not as motivated as, I wanna be here so I can give my wife the husband she wants or deserves. That's a different level of motivation.
Okay.
Yeah. I saw some over
Maybe
here.
one more.
Yes, sir. No more.
What if you got a, what if you got a patient that doesn't recognize the trauma and the stress that's causing those physical issues?
Every day.
Okay.
So, in my opinion, she can speak to this too, in my opinion, there's an awareness issue going on, right? Whether it's self-awareness, whether it's brain injury, whether it's blood flow to like the self part of the brain, it depends on how impactful or how activated that amygdala is and how much blood flow is not in that prefrontal system. We see it all the time. We see like, gosh, who was this just recently? Well, the patient that showed the all the whoop stuff. She was like, oh yeah, I've dealt with that, da 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 da. And then we have a conversation, and it's like, hey, listen, like this is a pretty big deal. She starts crying. She's like, I didn't realize. And I was like, okay, like it's cool, it's totally fine, but you can't just push this aside like you've done your whole life. That doesn't work. One of you might not have POTS if you didn't do that, right? We've got to get you strong enough to the point where you can tackle that, and then all of a sudden you can probably have these outcomes like she was saying. We can get that system to a point where it can be resilient enough to dive into that, and then all of a sudden you can have these breakthroughs. I got a great little story. We worked with a patient who was a trauma therapist. Well, he was married to a trauma therapist, he was a psychologist, okay? First month, he came in with CRPS of his right ankle, POTS diagnosis, all these weird autonomic things. Severe trauma as a child, went into the field, that's his philosophy, I'm gonna work on the trauma, work on the trauma, work on the trauma. First month, he didn't work on the trauma. He was like 40, 50% better in the first 30 days. And then he starts going back to work on trauma. He backs off and slows down significantly and actually starts to go backwards on how he feels. And I had 2 months worth of conversations, like literally every week he was in there. Why are you doing this to yourself? You need to back off. You can't tolerate it yet. I understand where you're coming from, but you can't do it. Well, we get to the end of his treatment program. He wasn't much better than he was that first month. And I said, listen, like this is over the holidays, so he ended up, I was like, you got 1 visit left. I want you to come back in a month. Don't do anything. Come back in a month. Let me know how you feel. He's starting to feel better because he wasn't doing his trauma work. Or he worked on the little t, like people call it. I think trauma's trauma, but the little t, he started working on that so it didn't flare him up as bad. So going back to the motivation, sometimes you're dealing with stubbornness too.
What
Yes.
would you say to a potential patient that's interested or that has skepticism about the systems failing them? Like, how would you help with like that hopefulness? Do you know what I mean? Like pessimism. I think my
When you say
daughter,
the system,
like neurology
system?
didn't really help, cardiology didn't really help. Like, you know what I'm saying? So someone that's like, why would this help me?
Yeah.
Like, what would you say to somebody like that, where they're like, I don't even want to go?
I'll take it. So I think this is where the education piece comes in. So we'll do the HRV testing or the autonomic testing. We'll do the neurology testing. Usually those patients, we're going to find something on. And we're going to be able to say this part of the brain controls that eye movement. So when this part of the brain that is responsible for these symptoms, like if it's 1-to-1. And so it's really, I think, the education process and be like, listen, we do this all the time.
Yeah.
Like, you can walk back there and ask any patient, do they feel better from the day they started? Every single one of them is going to tell you. Okay, not every single one, but every single one is going to tell you yes. It's generally the ones that don't listen are the ones that will tell you and, or they're the ones that leave the bad reviews. So
It's basically objective, like you have.
yeah, well, it is, but it's
clear
also, they need to
examples.
know that somebody understands what's going on. And that's, I think, what we do really, really well, is we hear them, we help them understand that we know exactly what they're going through, and that we can do something about it.
Yeah.
We might not be the whole thing, that's why we don't claim to be the whole thing anymore, which the first few years, we're all eager, we think we can fix everything, and it's just, at this point, it's very obvious that our role is to get people that 75 to 85%, where then everything else seems to just work better. Everything works, everything that we do works. It's just there's a time and place that works best for it. Our role is to get people out of the pit of misery so their head's above water, and then everybody else is, it's just easier for all of us. That's what I think our role is. So, anybody else? Yes.
I'm just curious how many people with PODS or who come to you for a consult who appear to have PODS have been self-medicating with alcohol, say, to cope with their,
Sure.
say maybe they're pretty functional in their day-to-day life, but
Yeah.
they've been, again, self-medicating by coming home after work and having 3 to 5 drinks a night or whatever, and how do you address that aspect of
That's a great
their
question.
behavior?
Well, so I can't be a hypocrite because I love a good old fashioned. But it's a good question because it's different answer for everybody. Like obviously if you don't drink, you're gonna be better off. But then there's those patients who, if they don't have a cocktail at home, they're gonna like scream at their wife and I use men because it's very common. We've got an alcoholic husband of a patient with FND that keeps flaring her up. Right? And so what she was talking about is an FND patient at the very end, right? Not an epileptic seizure. And so the answer is we'd love for him to get off of it. I've had another patient who was addicted to alcohol and we tried to help him, but he didn't have the desire or the ability to quit alcohol and he died within a year. He was like 30. And so for what it's worth, like Kimia here, she used to work in an alcohol facility and so she was with us while that was going on. And she's like, you gotta be careful because it's gonna shut down the GABA receptors and it's gonna drive them absolutely crazy if you pull them off right away. So there's a lot of, it's a very, very good question. But what I would try to do is work with all the professionals to make sure we're on the same page. Like a phone call can go a long way instead of just sending notes. So I hope that answered your question.
Yeah.
Awesome, thank you. Good, okay. Thank you, everybody.
Well, we always like to to give everyone a chance to share their services before we leave. And I apologize for the food. This is supposed to be coming any minute. We delivered it to the wrong clinic for some reason. In California, I guess. So it'll be to go. You can take it to go when you leave. I apologize. Yeah, Dr. Raymond's clinic in California. Thanks, Dr. So Kendra, do you want to start us off?
Yeah, sure. Hi, my name is Kendra Gimble, and I'm the owner of Hope Social. And that is a support program and a life coaching program for teens and young adults who are just feeling isolated and alone, maybe struggling with some depression or anxiety, and just need a place to reconnect and get some tools for healing. And we meet 3 times a week, but they sign up for a month at a time, and kids are staying around for quite a while. So I think our kids need friendship and connection again, so that's what we're working on.
And it's a beautiful place. If you ever get a chance to go visit it, it's a really, really beautiful place. Ashley.
I'm Ashley Harris. I do business development for Bella Vita TMS. We do quantitative EEGs for personalized TMS protocols. For those of you who do not know, TMS stands for transcranial magnetic stimulation. It's indicated for individuals with treatment-resistant depression, and it's basically prescribed for major depressive disorder. That's my pitch.
That's your pitch. Short and sweet. I like it.
So hi, I'm Taylor, and I am the community liaison in this area, or all of the Scottsdale area, for Behavioral Health Connections, which includes Via Linda, Valley, and Quail Run Behavioral Hospitals. So those are all obviously inpatient facilities that treat adolescents, adults, as well as geriatric adults. And we also have multiple intensive outpatient programs that coincide with our inpatient programs. Sums it up.
I am Dr. Melanie Dooley. I'm a naturopathic physician, and I integrate naturopathic medicine with neuroscience and energy psychology techniques to help women and men heal from chronic illness and chronic pain, not manage it. I'm tired of managing all this stuff. So I'm passionate about helping people heal from these things, and without using invasive procedures, drugs, surgery. I love this kind of work and the work that we've been talking about here, and I'm very glad to meet everyone, and thank you for letting me be a part of it.
And you're going to be our guest speaker in April.
I will.
Hi, I'm Camille Wright. I work with PEMF with far infrared and building healing rooms right now. That's what I'm talking about mostly. And a nutraceutical company, what it's called Nui. Thank you.
I'm Jane Reynolds. I'm the mental health nutrition coach. I help people tailor their diets to help support their mental health the best way they need to help with. We try and get to the root of what's causing the problems rather than just letting it go by the wayside and just throwing, the Mediterranean diet at it. We're just trying to get to the bottom of what their specific needs are, and then shoring them up with nutraceutical support and diet to resolve their issues.
Michael Lassard, I'm the CEO of Pastoral Care Associates. We provide spiritual supportive care to hospitals, care centers, and patient care as well. The importance of pastoral care services and spiritual care has been documented over the last 50 years. And so we provide that kind of quality care, and we also train chaplains in the field.
My name is Mason Lundell. I'm the owner of Unchained Wellness Clinic. We're a functional psychiatry office, and we do ketamine, Spravato, TMS. We also have IV clinic, and we kind of have an attached wellness center to us. We have cold plunge, infrared sauna, red light therapy beds, compression suits, the suite of kind of treatments that way. So.
I'm Dr. Janine Crafossi with Arizona Chiropractic Neurology Center, and as Dr. was saying, we are, Dr. James, sorry. He and Dr. Bohr and myself, we're all supportive of each other, and we each have our own little specialties and niches. I did miss last month's meeting, so I do apologize. We have just recently brought on QEEG, as I know some of the other facilities around here have, and hyperbaric. So we're just looking at, continuing to maintain the connections to share patients and to, help the community like we all are.
Yep.
So, thank you.
Thank you.
Trish Tremert. I'm also chiropractic functional neurologist and just recently returned to the Valley and kind of been connected with Dr. Grafossi.
Agnes Chow. I help people upgrade their human operating system. And through a number of methods, but Psych-K is one of the techniques that I predominantly use. And I've been able to use it to help veterans overcome suicidal thoughts, often in one session. And so I'm a retired aerospace engineer, so now I connect with my divine heart, and I follow the guidance, the divine intelligence that comes through me. So one of the key things I do is my nonprofit activities, which is the Empowered Heart, and we offer stress relief programs and also self-defense training for women.
What's the name of your nonprofit?
The Empowered Heart.
Empowered Heart.
I'm Charles Jackson. I'm a brain health enthusiast. Say that 3 times fast. And I'm non-clinical assistant to Agnes.
I'm Terry Nelson. I'm a licensed professional counselor, and I have my own practice called Live Life Counseling. I work a lot with trauma. I do EMDR, only at the right time, right? To incorporate the right work.
My name is Veronica. I run the mental health program for Cornerstone Healing Center. We've been open, Cornerstone's been open since 2017, but our virtual platform for mental health is going to be open a year just in a few days, which is really neat. We take access, we take other insurance supports, and it's completely virtual, including telehealth services with a psych NP, which is a great benefit to reach kind of the whole community of Arizona.
Great. Hi, my name is Janice Huey. This is a great diverse group. I'm really enjoying it. I've been here a few times, so I don't think it's been as diverse as today. If you want more information about Irlen syndrome, go on the MN1 website. If you know somebody that's suffering with chronic migraines, headaches, visual disturbances when they read, they have difficulty reading, ADHD, brain injury, autism, people with any kind of brain disorder may have it, and we can help them feel a lot better and be able to function in their environment, be able to read better and get rid of migraines. We've done military studies recently with 380 veterans that had syndrome, that had head injuries, and we were able to help them. So if you want more information about it, you gotta hear something 30 times in order for it to register. So if you go on the AMEN website and read about Irlen syndrome, it'll probably be in there 30 times and it might register. So interesting.
For me, it's like 130 times.
I'm also an occupational therapist. That's how I got involved with that. Sorry.
Nice, no worries. My name is Debbie Elder. I am recently with Canyon Health Centers. They're a new practice that just opened in December, and they treat ages 5 to 18. We have partial hospitalization, intensive outpatient, medication management. We have a Thrive with Pride program for adolescents who identify as LGBTQ+. Some great services. We take the access plans and a few of the commercial plans. So for those of you that treat adults, if you have, if they have kids that are just struggling. I mean, it's hard sometimes if mom or dad has some kind of chronic illness, and then you have these kids that are kind of dealing with a lot of feelings. So I have lots of cards. If you're interested, I'd love to show you around the practice.
Thank you. I'm Barbara Brown. Great presentation. I published Together AZ newspaper on real paper, and it's been around since 1991, started by my late husband, focusing, it's for the community, but anybody really, on behavioral health and addiction recovery, and I'm always looking for stories and writers and articles, and this is a room full of people that we could fill up a couple of years of the newspaper here, I'm sure. The website is togetheraz.com, and you can find my email there, and anybody interested, I'd love to talk to you. This would be really good, because I think what the paper provides is the community out there that is not in this industry and not sitting in rooms like this. They need to know about this kind of stuff.
Yeah, where to go. That's together, Arizona.com.
I'll give you a card.
Thank you.
And I'm Marvin Smith. I'm Dr. Patrice's husband, and I always find these very interesting. Every time we come here, it's something else clicks up here. Thanks for having me.
All right, yeah, and to me, that's what it is. It's a learning opportunity. That's why I'm here. I'm really a connector. I'm Dr. Patrice Smith, and I'm a connector because I deal with folks that you want to say, we need a healing plan. Yes, you've been in chronic, you're in trauma, you're in all those things, but you need to say, how do I heal? How do I not be stressed? How, like your case studies, it's like, of course, all mothers, all dads know you just gotta go, you just gotta do, you need to do this. Well, I was in the Western medicine. I dealt with all the diseases they gave me and what they thought. But I also went and started college at 40 and got 5 degrees, so I got my PhD last in natural health. Because it's like, we want to grow old with all the diseases you're telling me, and this is a huge paradigm shift. So I share, like I will be going to the cardiologist next week. You actually would really like them, the Wolfsons. And I will take this because they have begun to open their outfits here in Scottsdale. But so I find those people, I found yesterday a biodentist. Most of the people that work in dentistry went, what? What is a biodentist? That's the dentist you want when you need crowns, when you need, because you had to get mercury taken out, but we don't know that. And so it's like when you're doing that evaluation and case study, it's like that helps them. But if they get there, it's like I have people that have been 40, 50 years on depression medicine. Well, you know, that was because when I was little, and so it's like I'm the one that's chatting with you, or being stopped, literally walking down the street or in grocery stores and saying, it's aha moments. We need to wake up the intuitive idea development because you're the head of the team. And so we find a healing circle for you, which is then when I say, here's the naturopath, let's try there. You know, we don't have to have 1 billion drugs to make you feel better. Or when I love Dr. Daniel Amen, when I give these and the brain health, I go around and I tell folks and I go, this is your brain. Hold on to it for a minute. Because they never thought, because all they ever heard about is, that's that mental illness, don't talk about it. Their parents are saying, don't talk about that. You know what, you'll be fine. Pull up your bootstraps, all of that. And so it's like, people don't even know what they need and they don't know what to ask. We were always told, relax. How the heck do you relax? You know, and now we have a lot of people that will teach you how to relax. Just pop up to Sedona and have $10,000 in your pocket. Well, I don't know a whole lot of people that can do that. And so it's like, I can help you for free to help you. And so that's what, and I love your brain.
Thank you.
It's like, this is great for seniors. Great, great. You know, I got media communication. Take this and help it with seniors. Say, wow, put this up there. There's the silver brain. You know, and it's just, so I enjoy hearing all of you and what you do, because then I take this for free and I say to the other folks that I'm dealing with, their doctors and all these specialists, I got somebody that you want to see. You know, and that's, or even you, like I said, I've had a healing room or a healing closet from forever, but they don't know how important that is. Because I got the psych degrees too, and I can tell you that. You know, I mean, so, but yeah, and it was very enjoyable. Now, do you work with him?
We don't work together, but we do.
No,
the
we do
same
But
similar
you
thing.
stuff.
compliment
Yeah,
each
different
other.
parts of the-
Okay,
different parts
because
of
I
the valley.
didn't quite, when you were saying, I was like, okay, yeah. So anyway,
From the
that's
same
who
people.
I am,
Thanks,
Dr.
everyone.
Patrice.
Okay,
Holy.
I'm Polly. Dr. Toppleway, and I got along, and they
I love Dr. Amon's work, so I took his courses four times. I'm certified by him and a licensed brain health trainer. I am trying to change the world. I also teach nurses, and I'm bringing this information that you guys want, or not want, but we learn to them so that they start off as healthcare professionals.
More holistic.
Yeah, so it's real good.
And I'm grateful to Holly. I met Holly and she invited me today, so great to meet
I
everybody.
got so excited.
It is really good. I've actually so my name's Sherry Carnival. I own Evogenics, which is holistic wellness solutions to provide solutions for epigenetics. So just really feeling empowered in our ability to not be a victim to our genes, but to fully express our fullest potential with the modalities we have. So we have different modalities, including biosound therapy, Emisculpt, Emicella, power plate, all sound healing. There's a lot of different modalities that we combine to help empower you. So again, I'm starting to learn some of the neuro stuff with the eye training. That's amazing. So I'd love to learn more from you.
Sure. Okay.
Yeah.
Thanks for being here.
Thanks.
I'm John Mulligan, and it was interesting that alcoholism came up in here today, and that's what I do. I'm in the substance use disorder, mental health field. I help people get sober, and it's a huge part of what we're talking about.
Yeah.
And so thank you for bringing that up, because you're right. I mean, it's in the way that you talked about it, just bringing it into the space, it's tough.
Yeah.
And to get to the why, that these individuals use alcohol is so key, and then allowing them to know that once they're there and they know why, you can deal with the trauma, the neurological conditions, and just bringing it all together to give them better quality health.
Yeah.
Amazing. Thank you for having me.
Thanks for being here.
Thanks again. Feel free to mingle, share business cards. Please grab a lunchbox over there. Apologies that you're having
So you're